Welcome to Behind the Sports Medicine Podcast, the podcast that pulls back the curtain on the evolving world of sports science. I'm Andrew Rizza, an athlete trainer with decades of experience in professional, collegiate, and high school sports.
And I'm Cameron Roth, an orthopedic surgeon and a consultant for the Chicago White Sox.
In each episode, we'll explore the real-world challenges and opportunities facing today's human performance professionals.
Our hands-on experience is transforming sports medicine and breaking barriers through innovation and teamwork.
Hey, everybody. Welcome to this week's Behind the Sports Medicine Podcast. Today, we have Dr. Nick Rose, who is a hand and upper extremity surgeon in Southern California with extensive experience treating athletes across multiple levels of competition, including baseball players dealing with complex hand and wrist injuries. Today, he joins us to break down one of baseball's most unique injuries, hamate fractures, and explain why these seemingly small wrist injuries can have such a major impact on big league hitters. Dr. Rose, welcome to the show.
Hey, thank you so much, Andrew. Thanks, Cameron.
What exactly is the hamate bone, and why is it particularly vulnerable in baseball players?
Well, the carpal bones, you have 8 carpal bones basically between your forearm bones and your metacarpal bones. And they're these 8 little marble-shaped bones, if you will, in the wrist that form the wrist, and they articulate with one another. The hamate is one of those bones on the ulnar aspect of the wrist right here, and it's actually the hook of the hamate. It's a hook that sticks up into the palm from that bone. So if you think of the hamate as the church building, the hook of the hamate is like the steeple that sticks way up into the palm.
That's actually a really good analogy. What's so funny, I just put together a presentation on this. I'm presenting it next week at a sports medicine conference. So that's a good analogy that I'm going to use next week. Is there something you think about modern swing mechanics or grip style or bat design that really contributes to these injuries?
Well, there is. Inherently, these injuries, we see them. I consult for the NHL too, and I actually see them in a lot of hockey players. We see them in golfers, and we see them in baseball players, and it's all the stick sports basically. And the problem is that hook of the hamate is right in this area of your palm. So if you take a baseball bat, the knob of the bat is where that's going to contact. In the modern game, it's all about power. It's all about home runs in today's game. So if you've played baseball, I played baseball in high school. The traditional, if you go back to the Ty Cobb era, and actually I have a bat here. I can show you guys. So in the Ty Cobb era, they actually spread their hands apart when they would bat because they would have more bat control. They could place the bat. In the modern game, it really came down to bringing the hands down, and then the knob there, you can see the red knob against the ulnar aspect of my hand. So I'm a lefty. This is my right hand that would be affected. So in the modern game, you have this palmar hamate grip, and what the players do is they grab the knob. So so a lot of times the small finger is free, and what that does is, and you can do this on your own. Your bat is much whippier when you do that, and you can get much more torque. So your bat speed increases and you're going to hit more home runs. Great for the game, great for hitting home runs, not so good for the hook of the hamate, because now instead of the ulnar side of my hand butting against it, you have your hook of the hamate right on top of that bony knob. And that's why we're seeing a lot of these injuries in big star players, especially power hitters, Mike Trout, as an example, who had one of these. So that different grip is really increasing the risk of these injuries.
So we had on Kurt Schilling a couple of weeks ago, and he talked about how baseball has changed. So all pitchers are going for top velocity. And just like you said, all hitters are going for big power. When do you think that changed? And then in your extensive career, have you seen an increase in hamate injuries since the, adoption of this new batting grip?
Well, it's interesting. The game, I'm a big baseball fan. As I said, I'm a Dodger fan, grew up in LA. And, you look at baseball in the 70s and, it was much more of the technical game. You had this, Lou Brock, you had the singles hitters, stolen bases. You had Phil Niekro, you had the knuckleballers, you had the curveball, the sliders, Fernando threw the screwball. So it was much more maybe a technical game then, where it wasn't all about power. It was about finesse and different pitching. Nolan Ryan is probably notorious for throwing 100 miles an hour. And I really think of Nolan Ryan as maybe bringing that game into the velocity era and where we are today. And I think part of that is, the radar gun, and you see that on TV. I mean, you see that at the stadium. You can know exactly how hard that is. And I don't know about you guys, but if I'm pitching in front of 50,000 people and my number is on the scoreboard, I'm going to try to hit the, high 90s or the 100s. So that's where I think the transition came about. The game has become much more visible in terms of statistics, metrics, scoreboards, television, exactly where your pitch is going and how fast it is. In terms of batting, I think, as we alluded to earlier, the Palmer Hamate grip and the strive for power and home runs, and we've really seen an uptick in these hook of hamate injuries because of that.
Looking to get back in the game and feel your absolute best? Boston Orthopedics and Wellness has you covered. At Boston Orthopedics and Wellness, they're all about helping you recover faster, re-energize your body, and truly revitalize your health. Whether you're dealing with an injury, looking for cutting-edge recovery therapies, or exploring innovative treatments for orthopedic conditions, their expert team is ready to guide you every step of the way. From advanced regenerative treatments like PRP, stem cell therapy, and peptides, to performance and wellness services like NAD+ therapy, men's health optimization, and weight management programs, they offer a comprehensive, personalized approach to getting you back to peak performance. This isn't just treatment. It's a path to moving better, feeling stronger, and living pain-free. Boston Orthopedics and Wellness is where your comeback starts. Mention Behind the Sports Medicine podcast to receive 15% off your first scheduled appointment. Learn more and start your journey today at bostonorthopedicandwellness.com. You build recovery plans, rehab protocols, return to sport timelines because you know outcomes don't happen by accident. Your financial life deserves the same intention. Bode is a fee-only fiduciary firm that starts with a plan. Your goals planning statement, a personalized roadmap that keeps your money aligned with where you're actually headed. Built around your life, backed by conviction. See what real planning looks like at betbode.com.
So as athletic trainers that are listening, what are some of the clinical presentations for hamate injury, signs and symptoms? And then how do you differentiate between that versus just regular wrist soreness?
Well, that's a great question, Andrew. And the thing is, it's really, you have to work with trainers, hitting coaches to see this, because the hook of the hamate is a hard thing to diagnose, and it's probably missed in many scenarios because, number one, a lot of maybe physicians don't know about the hook of the hamate. Number two, standard x-rays will miss the hook of the hamate fracture because it sticks up from the bone. So if you get two views, you're not going to see that. The standard x-rays, a carpal tunnel view, and even that has only about a 40% sensitivity in picking this up. Number one. Number two, we're in the era of, hey, play through the pain. Professional athletes do that. They have contracts to play for, division titles to win. So I think as a trainer, as a hitting coach, what I think you look for is altered mechanics. A big tell with hamate fractures is the inability to drive the inside pitch to the opposite field, to just drive it for any power. If you start to see that as a trainer, that's another thing too. Another thing is a decrease in grip strength. I think what should happen in Major League Baseball is you take a baseline grip strength in all players at the start of the season. You monitor that maybe every 2 weeks, because if you have a hook of a hamate fracture, you're going to see a drop in that grip strength. So I think that's where really athletic trainers, hitting coaches are so valuable here, to look at the mechanics and look at that decreased grip strength in a player.
What is the danger of, dealing with youth athletes? For a lot of athletic trainers, they're dealing with high school athletes or adolescents. Is there any danger to not diagnosing this injury?
Well, it's like the scaphoid, and even more so than the scaphoid, it has a very high non-union rate. Non-union means that when it's broken, it doesn't heal in the typical 6 to 8 week period like most bone fractures do. What's different from the scaphoid is that in the scaphoid, if you develop a non-union that's not recognized, you develop a characteristic pattern of post-traumatic arthritis. The mechanics of the wrist are thrown off, you wear down the cartilage, and ultimately you can need a wrist fusion. Not the case with a hook of the hamate non-union. Basically, it's just persistent pain. We do see other issues that can happen with that. Basically, the ulnar nerve is adjacent to the to the hook of the hamate, so you could get numbness and tingling or even weakness of your hand because that nerve is affected. You have the flexor tendons to the ring and small finger are right next to it, so you can theoretically get a tendon rupture. So that's probably the longer term things that you can see with these injuries. In youth sports, when the really younger kids, say 11, 12, 13, their growth plates are not fully developed. So we don't see the hook of the hamate fractures in that group as much. We'll tend to see it maybe in the 17, 18-year-olds more so.
All right, walk me through your algorithm. You're in your clinic. You've got Mike Trout on your schedule, and then you have a 17-year-old high school baseball player. They both walk in. They say, Dr. Rose, I've been having a lot of wrist pain, a lot of hand pain for the past 2 to 3 weeks. My grip strength has decreased. I'm having trouble hitting the ball. What do you do the same for both players, and what would you do differently?
Well, we like to believe that we really treat everybody the same. And I think the workup is going to be the same. Obviously, the first thing is going to be a detailed history. When did you notice this? Did you have a specific injury? Do you notice it with certain pitches? Do you have trouble hitting inside pitches? So that history is very valuable. Do you have any numbness or tingling in your ring and small finger, weakness of the hand? So that's number one. Number two, of course, is the physical examination. And first of all, we take a grip strength and we compare both sides. And if you see a real drop off in grip strength in their non-dominant hand, typically, so if you're a right-handed batter, it's going to be your left hand where you fracture your hook, your hamate. That'd be something that would stand out. Now, as a hand surgeon, there's entire conferences. This is the ulnar aspect of your wrist. There's entire conferences on ulnar-sided wrist pain because it's that complicated. There's literally probably 20, 30 entities that can go on in this region: ulnar impaction, TFCC tears, ECUs, instability, fractures of other bones, piezotriquetral arthritis. So palpation, the exam is very important in hand surgery because literally if you palpate 1 centimeter to the right, to the left, or distal, that's a different area that'll tell you information. So the classic finding here is going to be tenderness over that hook of the hamate. So both athletes would get a wrist series. We would get what's called a scaphoid series, but we would include a carpal tunnel view, which is basically it's kind of taking a view like this down your carpal tunnel, because if that hook of the hamate is sticking up, you would theoretically try to see it again. It's only sensitive 40%, but the other things you would consider is an MRI. An MRI is going to be much more sensitive for maybe early hamate, repetitive type inflammation in the bone or an early fracture. That's going to be 100% sensitive, but really the gold standard is a CT scan. What a CT does is it takes multiple slices through the wrist, not actual slices, but X-ray slices through the wrist, and you'll almost always see the hook of the hamate on that CT scan. I believe the sensitivity rate is about 92%.
So you get a CT scan, you see a non-displaced hamate hook fracture in Mike Trout, and then your high school baseball player. What's your discussion?
Well, the discussion, of course, the 17-year-old is going to be coming in with their parents. So it's a little bit of a different discussion. You're talking to two people. And sometimes that can make things even more difficult. So the discussion with both is going to be obviously recognizing and telling them about the injury and its natural history, and then going over treatment options. So theoretically, in an acute fracture, you could fix that. There is some literature that shows good results with putting a compression screw across that. I think most hand surgeons don't do that. Really, the gold standard of treatment is going to be in a 17-year-old. You're going to try to get this to heal with a cast. If you feel it's an acute injury, casting will get maybe a 50% union rate. This bone has about a 50% non-union rate, is my understanding. So I think in that high school athlete, you're going to try, they're young, they have great healing potential. You're going to try to cast them if you really feel it's an acute injury. With Mike Trout, and a lot of this depends on the history. If Mike Trout or either one comes in and they say, hey, doc, I've had tremendous pain for 3 months. It's right here. I can't bat. I can't hit an inside pitch. Well, now you're thinking more of a non-union. So the chance of that healing with the cast goes way down. So then you enter the discussion of excision of the hook of the hamate, which is you get rid of the problem. I like surgeries where you get rid of the problem. It's not going to refracture because the hook of the hamate is gone.
So I'm going to put my rehab hat on and ask the question. So if you have both of those players in your office and you're talking surgical intervention, either resection or putting a screw in versus conservative treatment, what is the timeline for return to play on both of those?
So my experience and the studies show about 7 weeks is return to play for both. So let's say the rehab, basically when you do the surgery is, the first 1 to 2 weeks is desensitization of the scar and range of motion of the fingers. Probably at 2 weeks, we start strengthening, light strengthening. And then by 4 weeks, we're maybe having them hit off a tee and then maybe soft, little lob pitches, hitting against like you play pepper type thing. And then really at 7 weeks, we have them in the, 6 to 7 weeks in the batting cage and hitting at that point. And then this whole time we're monitoring, we're sending them to therapy. The therapy is critical to, restore strength, dexterity, and whatnot, and also scar desensitization. The biggest issue here is that when you take something out in this area, that area stays tender and swollen for several weeks. But you can monitor these patients usually by their grip strength too, and usually when they're at about 90% grip strength is when they're ready to return.
And how much collaboration is existing between you, the hand therapist, the athletic trainer, strength coach, hitting coach during this return to play period?
Oh, tremendous collaboration. I mean, everybody's has different roles. And, the athletic trainer, the hitting coach, they're there every day. I am not. The therapist is there 2 to 3 times a week. And then the physician did the surgeon and knows what they found, et cetera. So I cannot stress how important communication is. So for the hitting coach, one of the problems here, realize that you have a player maybe who's batting 112 in the last month and they've had pain. So now all of a sudden their mechanics are all thrown off. So they've probably learned bad habits that have to be undone. So that complicates things in a more chronic case, where they now have to reteach those mechanics. Because think about it, in baseball, you have that pitch coming out, you have milliseconds to decide whether to swing or not. If you have something in your palm that every time you swing, it hurts, your brain's going to tell you, don't do that, don't swing, don't hit that pitch, don't hit that inside pitch. And you develop bad habits. The athletic trainer is critical in terms of alterations they can do, taping certain gloves, padded gloves, and whatnot, changing the bat. And one thing we didn't talk about is, stepping up starting with a lighter bat and maybe going to a heavier bat. And then the therapist is also somebody you have feedback with frequently in terms of they're concerned that their strength is not progressing. They're concerned that the scar tenderness is still significant with a lot of swelling. So I cannot express how important communication is on all levels.
I've got a question that you may get from some of your athletes in clinic. So you're diagnosed with a hook of hamate non-union. Are there any adjuncts that you use to try to get the non-union to heal? So bone stimulators, red light, PRP, stem cells, vitamin D and calcium supplementation, hyperbaric oxygen, anything like that?
Well, I'm not aware of any evidence-based medicine
Peptides.
and peptides. You forgot peptides. Everybody every day asks about peptides.
I should have led with peptides.
Absolutely. So, look, I think that those things, PRP, autologous fat grafting, stem cells, peptides, we really need more evidence-based medicine on those. The problem is there's so many different preparations. There's so many ways to do it that we don't have a standardized way to use them. And we don't really have great double-blind studies that can confirm that. So I'm not, and that's basically what I tell people. It's like, look, the literature at this point, we don't have the literature that necessarily supports that. Now, in a professional athlete, are they going to push for PRP? They might. PRP, as probably is better for There is some evidence-based medicine to support it, perhaps for more chronic tendinopathies, Achilles tendonitis, perhaps medial and lateral epicondylitis. I'm not aware of any evidence that shows it's beneficial for a hook of hamate non-unions. A bone stimulator, I think there's literature for that for other non-unions. I think I would, if somebody opts to treat it with a cast, I think a bone stimulator would be optimal. For a layperson, what a bone stimulator does, it's very interesting. When bones heal, they actually have a positive and negative charge, and your body lays down bone where they see the negative charge. So what a bone stimulator does is it augments that positive and negative charge to stimulate more bone healing. So you wear this unit. They're different units. It's usually about 3 hours a day, I think, are most of them. And it doesn't hurt or anything. You just wear it over your cast and it augments that. Peptides, I think that I think we're learning about peptides. I think especially here in Newport Beach, if I have a patient that doesn't ask about peptides, it's something's wrong. But I think there's probably promise with peptides. I think we need some studies to see if they're beneficial. And then the red light and those things, I get asked about that. And again, I think I don't know if there's evidence-based medicine for that, but I don't think it's harmful. If somebody is pretty gung-ho and say, hey, I want to go do red light theory, whatnot, sure, that I don't think that's harmful, but I can't condone it as necessarily being beneficial.
Okay, good. I'm glad I've been giving the same response to my patients that you give to yours.
and to be quite transparent here, we get the same in the athletic training setting and the PT setting, the same types of questions, and we answer the same way. I will say the red light therapy we do use, and anecdotally, the athletes seem to think that it's helping them with a little bit speedier recovery from more the traditional sense, but we're still providing all the other rehabilitation tactics, the manual therapies, other soft tissue manipulative techniques to help them. I want to go back to when we were talking about return to play and return to hitting. You talked about 7 weeks kind of being the timeline or the standardization for the timeline. Can an athlete get back to field play before 7 weeks, depending on position?
Absolutely. They can go back to fielding sooner. I think that, realize that this is one of those surgeries. I love surgeries like this where you're just taking something out. We're not waiting for a bone to heal. It's not like a plate and screw fixation where you're worried about the bone re-breaking. There's no hook of hamate left, so you're not re-breaking anything. So I think that certainly if the player's comfortable, again, they're padded by a mitt, depends on the position. If they're a catcher, I probably wouldn't recommend it. But I think for a infielder or outfielder, I see no problem. I've had athletes and baseball players go back at 4 weeks with this and play the field, and I don't have an issue with that.
Do you see that players post-op mentally trust their hand, or does it take them a while to gain that trust back?
That's a great question. And I think that every injury, people who aren't physicians, and even physicians probably, you're mentally, you don't want to reharm something. And I think as physicians, as athletic trainers, as therapists, we're also cheerleaders to really coax them along and tell them it's okay to do this. And I always tell patients there's hurt and there's harm. You might be hurting it, but you're not harming it. So if you go out there and it's still sensitive, that area where we took out the hook of the hamate, it's okay. You're not really harming anything. So you can expect that. So I think that's a great question, because I think telling the patient, the baseball player, look, we took out the hook of the hamate. You're not going to refracture it because it's not there anymore. It's like if we take the doors off your car, you're not going to get any more door dings. It's basically the door is gone. You can't damage it anymore. Now that's going to bring about other problems, but that's maybe not the best analogy.
That's a good one. As we look to prevention and future trends with these injuries, where do you think sports medicine is improving the most when it comes to wrist and hand injuries in baseball?
Well, I think where we're improving is with the athletic trainer's knowledge. I think the athletic trainer has come a long way to really be somebody there who's a daily basis, who's quite knowledgeable with these entities. And I think that's a huge difference to where we were, say, in the 70s. In terms of equipment, I think that There's some new bats coming out called the Axe Bat. With the Axe Bat is basically, I'll get my baseball bat here. So what it is it basically is a bat that has this has a uniform knob here. And what an Axe Bat does is the top part is basically flat. So the part where you lay your hamate against is flat, but you still have the knob on the other side. So that's one innovation. I think that the sophistication of analytics. We now know bat speed, velocity, all these things that we can really see. Hey, this guy's bat speed's coming down, the exit velocity is coming down. But I think adding grip strength, regular monitoring of grip strength for a batter, all of these innovations, I think, importantly, is going to get that person in sooner before they develop those really bad batting mechanics that could really affect them for a few seasons after they ultimately have surgery to deal with the problem.
We're focusing a lot on grip strength, and people are going to want to know, how do I improve my grip strength so I don't get a hook of hamate injury?
Well, I don't think you can necessarily do that, at least to my knowledge. I think that, avoiding the palmar hamate grip is one way you can avoid it. I think that padded batting gloves, they do make some padded batting gloves that protect the hook of the hamate. That's another option. Grip strength is, building your forearm muscles. That's where the athletic trainer comes in, building those forearm muscles, squeezing the putty, squeezing a rubber ball. Those are all things you can do to improve your grip strength. And theoretically, I think if you improve your grip strength, you can maybe generate the same power and bat speed without having to go to that palmar hamate grip that puts that hook of the hamate at risk.
I'm sure you have all these patients in your clinic who come in and say, "Oh, I'm just squeezing the stress ball and getting my grip strength back." I tell them, don't do that, because it just makes them hurt worse. I don't know what you think about that.
100%. I think that especially you'll see that in elderly patients with trigger fingers, and that's specifically an activity that's going to aggravate their trigger fingers. So you have to be careful. I think, and, patients inherently are like, "Hey, I'm going to exercise and make this better," but as you said, especially a hook of the hamate fracture, they have a non-unit, that's not going to help them out. So you have to be very diligent about what the underlying problem is, and if that grip strength is going to really aggravate it.
So you've worked with a lot of high-profile athletes over your career, and it can either be specific to this hamate injury or any hand or upper extremity injuries that you've experienced. Are there any cases that stand out to you that were educational or interesting or made you think extra hard? Because it's always interesting working with very high-level people. It's not only a thrilling experience, but it can be very educational and make you a more well-rounded physician. So if you have any stories or knowledge that you've gained over decades of experience.
Well, one thing I can tell you is that hockey players, I take care of a lot of NHL players, and they're just a different animal. I almost feel as a hand surgeon, you can kind of get it right, and they're going to just go out and play hard and not complain. So I think that one thing I've noticed that NHL players are just really different than other professional athletes in terms of their ability to play through pain and really probably get back earlier than maybe some other athletes. And that's not in no way degrading other athletes, but that's just something I've noticed, number one. Number two, I think what taking care of professional athletes changes is that there's a lot of pressure to get them back. And I think, we're trained to, nothing for 3 months, don't do this for 3 months. And I think that what taking care of professional athletes does is it really pushes that envelope where you say, well, okay, can I cut off 2 weeks here? Is it really going to do damage? And I think that, sometimes that's good, sometimes that's bad. But I think taking care of professional athletes has allowed us to really kind of cut down the rehab on a lot of these injuries. I think a great example is some of the work that Steve Shin is doing with the ulnar collateral ligament. There you go. The internal brace of the ulnar collateral ligament. I mean, that used to be an injury that, you couldn't do anything for 3 months, but with the innovation of this internal brace, using the ulnar collateral ligament reconstruction in the thumb, we've really been able to push the envelope and get those athletes back to throwing and back to their sports much sooner.
We just did an episode on thumb UCL, which hasn't been released. So I'm going to pivot. If you're using the internal brace, what's your return to play for your athletes?
So I think these athletes can go back after about 3 to 4 weeks, with the internal brace. And, I think that it protects that ligament repair, and it allows, those anchors are very difficult to pull out, are very strong. I'm not going to lie to you. I think every athlete I send back at 4 weeks, I'm always a little nervous. We're still pushing the envelope, but I think there's always going to be that player who, goes back a little early and doesn't do well. I think a great example of that is, I think Mike Trout, with his hook of hamate injury, tried to come back early in that, I think it was 2023 season, and really had to shut it down. So it doesn't always work out, but I think that, most patients it does.
I'm going to ask one final question on positional hitters. So meaning power versus contact. Is there a challenge with return to play with those two different style hitters?
Oh, no question, because your power hitter they're really pushing to the max. They're doing that Palmer hamate grip, and realize the Palmer hamate grip puts basically it's a 360% increase in pressure on the hamate. So that's the player who you really have to be careful with, because they're really going for bat speed, et cetera. So if you have somebody who's maybe a singles hitter who doesn't depend on power as much, that's probably an easier player to get back, because they're going to be all about bat control, not so much about power. So I do think there is absolutely a difference between what type of hitter you're talking about. Now, that was maybe more the case even 10, 20 years ago. Almost everybody's hitting for power now. I mean, you have leadoff hitters now, Shohei Ohtani. You have leadoff hitters who hit home runs. When I played, I mean, I'm not a big guy. I batted first in high school, and I stole the bases and I hit singles. That was my job. I was not a power hitter. I don't think that classic presentation of the game exists anymore. I think every positional player now is hitting home runs.
It's probably harder to pitch around a lineup now.
Especially if it's the Dodgers.
Yeah, right.
Before we get to the lightning round, you brought
Cam's do you have a question about Ohtani?
Of course I have a question about Ohtani. So we've interviewed a bunch. We interviewed Curt Schilling and Brad Pearson from the Red Sox and Tom Gill from the Red Sox and the Patriots. And I always have to ask, and I have to ask you, what do you think of Ohtani?
Well, I'll tell you, my wife and I just went to Japan a couple weeks ago, and I've never been to Asia. And first of all, amazing country, amazing people. And I understand Shohei Ohtani and his demeanor and how kind he is and polite and classy, much more having gone to Japan, number one. So he's an amazing human being, first of all, which I really admire. But you look 20 years ago, if somebody was batting and pitching, and they were like, maybe they were a decent batter and they were a decent pitcher, maybe the third and fourth pitcher in your lineup, you say, that's amazing. That's amazing. But Shohei Ohtani is a great pitcher. He's pitching 100 miles an hour. He's obviously a great hitter. I mean, I think the game in the playoffs last year against the Brewers, I believe it was, he had 10 strikeouts and 3 home runs. I mean, if you had told me that 20 years ago, I'd say that's never going to happen. That's impossible. I cannot say enough good things about Shohei Ohtani. And from an orthopedic standpoint, he's had a redo Tommy John surgery. He's had 2 Tommy John surgeries, and he's throwing 100 miles an hour with a revision Tommy John surgery. So from an orthopedic standpoint, he's unbelievable.
He is truly unbelievable. That's, in the same ballpark as the answers we get from all the other respected physicians and former World Series champion pitchers. It's amazing.
It was, I think Curt had said it best. He said, any day he's pitching, he's the best pitcher. Any day he's hitting, he's the best hitter. It's like, you can't get better.
Absolutely. Well, just to give you an idea, when I was a kid, I loved Baby Ruth candy bars, and I found, Babe Ruth was an actual player, and the legends of Babe Ruth. Oh, this guy hit home runs and he pitched, and I'd be like, really? really, a guy pitched and hit home runs. Is that maybe a myth? And they're just saying that. But now with Shohei, I mean, he makes Babe Ruth look like an average player. I think he's the most amazing athlete in any sport in terms of what he does that we will see in our lifetimes.
I think I would tend to agree.
100-year player, right? Probably not going to see it again.
All right, hit him with the lightning round.
You lead off.
One baseball injury myth you wish could disappear.
Play through the pain. I think that with today's athletic trainers and orthopedic surgeons, I think there's no excuse for that. Get it checked out. Don't be a hero because you're ultimately hurting yourself in the end.
Most underrated injury in baseball.
Got to be the hook of the hamate, for sure.
It all comes full circle.
That's right.
What's the hardest sport for rehabbing hand and wrist injuries for return to play?
I would really have to go with baseball because there's so much, look at a pitcher, how they hold the baseball, how the dexterity, the finesse. It's really the one sport in terms of hands where you have to have grip strength, you have to have power, you have to have dexterity. So by far, I would say baseball is going to be the most difficult.
One tool for hand and wrist rehabilitation that you can't live without.
Well, I hate to refer them as a tool, but I would say occupational therapists and athletic trainers. I think that these are the people who see the patient every day, that put in the work. I tell patients, look, my surgery is 50% and your rehab is 50%, and you have to treat it that way. So I would say that, the tool of, the occupational therapists and the athletic trainers are vital, as vital as the surgeon.
Most impressive comeback from a hand or wrist injury you've seen in your career?
Well, it's not a hand or wrist injury, but I have to go with Kirk Gibson in hitting the home run in the 1988 World Series. I mean, the guy had 2 leg injuries. I think he had the flu. He hobbles up there. He hits the game-winning home run, and he doesn't play again the rest of the series. So I would have to go with that one. In terms of the upper extremity injury, I'd probably go back to Shohei Ohtani. The fact that he's not only pitching again after a second Tommy John surgery, but he's throwing in the high 90s up to 100 and performing like he is with those 2 surgeries.
Who's your favorite Dodgers player of all time?
Ooh, that's a hard one. I love Freddie Freeman. I was at the game. He hit that grand slam. My best friend invited me. I'm forever indebted to him. I just love Freddie, how he approaches the game. Going back, I really loved Ron Say in the 80s. I don't know if that name is probably shows my age, but Ron Say, the Penguin, played third base in the 70s, is another favorite of mine.
Being a baseball guy, what's your favorite baseball movie?
I got to go with Field of Dreams because if you are a baseball purist and you understand the beauty of baseball, that movie really captures it. Probably close second is Moneyball, the whole analytics stuff. Even though I'm a Dodger fan, I sort of love these little teams like the A's that have, the Tampa Bay, that have these analytics, that have successful teams without the budget. And I really admire that.
All right, this isn't necessarily a lightning round question. So you work with Red Bull Sports and extreme athletes.
Oh, they're extreme.
Yeah. So how is that different than working with maybe some of the athletes in the 4 major sports? And what are some of the common hand and wrist injuries you see with them?
It's very challenging because the whole mentality that they're doing these extreme sports in the first place translates to not listening to instructions, going back sooner than they should, taking risks. I mean, more than any other sport, these people are taking tremendous risks. They're, going, 100-foot jumps. So we really see pretty bad injuries. A lot of these are just straight out fractures, distal radius fractures, scaphoid fractures, perilytic fracture dislocations. So the injuries we see in the Red Bull sports, as you would expect, are going to be much more extreme. One place that's different is these athletes come in and they show me the video because there's a video of their actual crash and what they did. So they actually have the video to show me so I can see the mechanism of injury, which isn't typical of other. Well, you certainly can see it in Major League Baseball, NHL, whatnot, but maybe not in your everyday patient.
I have one final question.
Go for it.
For athletes, clinicians, or even players that are listening today, what's your biggest takeaway for them to understand about hamate injuries?
Well, the biggest takeaway is just to have a high level of suspicion. And I'd say the key thing is the palpation, know where the hamate is in the palm and where to press, because every hamate injury I've seen, you press there, it's excruciating pain. So just look at your palm and figure out where the hamate is and learn to palpate there and have a high suspicion for somebody who is their bat speed is suffering, or they're not hitting as many home runs, or they're in a slump. Number one. Number two is go get yourself a JMAR dynamometer and keep it in your office. And I would just I would keep a log of every player and measure them every 2 weeks. And if you see the drop off there, something's going on. And I can't encourage that enough.
That's fantastic. That's great advice. To go back to Field of Dreams, my daughter was going to Iowa a year ago, and she said, "What's in Iowa?" And I sent a video of that scene where he says, "Am I in heaven?" "No, you're in Iowa." And she just was like, "What? What are you talking about?" I said, "Just an inside Field of Dreams joke."
Well, it's funny when you talk about Iowa. My wife's relatives are all from Iowa, and when I was probably about 20 years old, I had to go to a wedding there, and I was like, I don't want to go to Iowa. I was a typical Californian who thought California was the only place to be. And so we went to this wedding at a little town, Indianola, and I fell in love with it. I mean, everybody walking to town to get ice cream, the fireflies, the people, the front porches. And I'm a big fan. I love the people. I love the state. And having now traveled, Texas, Tennessee, Montana, Wyoming, all these places, they're really just phenomenal places everywhere in the United States. But I do think Iowa is a very special place. It's amazing.
There's not a lot of states or towns in the United States that have small town squares anymore, right? So that's what kind of brings people together.
Yeah, well, that was the thing. I mean, the small town square, and everybody had everyone walked to ice cream in the town square and walked home. It feels like you're in the 50s. But it has that, mom and pop kind of feel. And it's a special part of the United States, I think. By the way, I love the Bobby Orr jersey. I noticed the Bobby Orr jersey in the back. I
like that.
Yeah. Are you a big Boston Bruins fan?
Yeah. Across from me, I have a Manny Ramirez bat that he used. I have a bunch of stuff up here. Cam's been up in this office. So
yeah.
I should have put my, my Carl Yastrzemski autographed 1975 World Series pitcher behind me for this interview, but the Orr jersey works.
Yeah, your jersey works. Me personally, hockey is my number one sport. I play ice hockey still. I'm a huge LA Kings fan. So you did the right thing with the Bobby Orr jersey. That photo of him scoring the game-winning, cup-winning goal is the most against the Blues. Is I think one of the most iconic sports photos that exist.
Yeah, that's a 100th anniversary Bruins jersey signed by him. So
nice.
It's going to be worth a little bit of something. So it's good. Well, Dr. Rose, thanks for coming on today. This was fantastic. I hope our listeners get the information they need from this talk, and hopefully the young athletes that are suffering from pain in that ulnar side of their hand get checked and get diagnosed appropriately.
Yeah, Andrew Cameron, thank you so much. In prepping for this, I watched some of your episodes. These are awesome. I mean, so I am a very big fan, and it's I do my kind of lunchtime walk to kind of clear my head, and I'm going to be listening to those podcasts. I have a lot to catch up on.
Oh, appreciate it, Dr. Rose.
We appreciate it very much.
It's awesome. Thanks for listening to Behind the Sports Medicine Podcast. Follow us on social media and check out our website.
The information shared on this podcast is for educational and informational purposes only and is not intended as medical advice. Please consult a licensed healthcare provider for guidance related to your specific situation. We'll see you next week.